Dr. Jaideep.
Hello.
Hello, hi.
Yeah. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, TNFOG with AMOGS Sexual Medicine Committee and AMOGS Robotics and Endoscopy Committee. So let us start the webinar with Saraswati Vandana. It's my privilege to introduce the conveners of today's webinar, Dr. Pradya Supe ma'am. Ma'am is the consultant obstetrician and gynecologist and also laparoscopic surgeon and lactation consultant. Ma'am has been attached to Surya Hospitals, Gen Hospitals, and ma'am is the secretary manager of Jogi and AMOGS managing committee member. I welcome you, ma'am. And it's my honor to introduce Dr. Madhumita Arun Karthik ma'am. Ma'am is the National Coordinator of Midlife Management Committee, FOXY, South Zone and TN State Coordinator of FOXY Presidential Activities 2026, FOXY Youth Cell Member, Secretary of Salem Chapter of ISAR. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. Can we have Sampath ma'am say slide, please? Pradnya ma'am will introduce. Pradnya ma'am, you will introduce.
Yes, my honor to introduce Dr. Sampath Kumari ma'am. Ma'am is professor and head of department at Kumar and Medical College. She is the FOXY Vice President in the year 2022, National Corresponding Editor of the Journal of Obstetrics and Gynecology of India, and Founder Secretary of the Tamil Nadu Federation of OGYN, and immediate past President of OGSSI. Madam, over to you.
Thank you, Dr. Pradnya, for the nice words. This is the second program we are doing, and I welcome TNFOG with the AMOGS Sexual Medicine Committee and AMOGS Robotic and Endoscopy Committee. And I welcome the AMOGS office bearers, Dr. Ramaya Prandre, the President, and the Rohan Palchekar, the Secretary, and our Chief Guest, Dr. Jaideep Tank and Kalyan Barmudi, and the Guest of Honor, Dr. Amla Madam and Anjalakshi Madam. And here this week we have one talk and one panel. We have the talk on robotic surgery by Dr. Manjula, chaired by Dr. Asha Rao and Dr. Reddy Desai. And we have the infertility and endoscopy panel, moderated by Dr. Rajesh Modi and panelist with Saravana Kumar, Sundar Narayanan, and Amog, Kesav Rai, Kesav Pai, Vanita, Monica, and Manoj. So, and I also welcome the MOCs, Pradhyana and Madhumita Selam. And I thank again the Amaya and the Rohan for giving us an opportunity to do program with the TNFOG and the AMOGS. Now we will go with the introduction of the chief guest. Amaya sir, did you want to tell a few words?
Yeah, sure, madam. I think after our last webinar, which was very well appreciated, I think this is our second webinar, and the collaboration is going stronger and stronger, and the feedback that we are getting from all across India is extremely positive. So thank you, Amla Devi madam and Sampath Kumari madam for this wonderful collaboration with AMOGS. I'm really happy and privileged to share the stage with my mentor, Dr. Jaideep Tang, past president of FOXY. Thank you so much, sir. You are such an integral part of AMOGS, and it's always a privilege to have you at any AMOGS event. We are also privileged to have Dr. Kalyan Barmade, the past president of IAG, very well-known endoscopist and IVF specialists from Maharashtra, from Latur, and we are happy to have Kalyan with us as chief guest. Also, we are very happy to have Anjalakshmi Madam, past president of TNFOG, for being the guest of honor this evening. My special thanks to Dr. Pradnya Supe and to Dr. Madhumita Karthik for curating this program and organizing this program very well. Special mention to Dr. Asha Rao, Dr. Riti Desai, our chairperson of the uh, Robotics and Endoscopy Committee of AMOGS, and to Dr. Pradnya Supe, chairperson of the Sexual Health and Sexual Medicine Committee of AMOGS, for excellently performing their duties and spreading the knowledge of such vital and key issues beyond Maharashtra to other members across the country. Indeed, it is great to have eminent faculty, the super champs of endoscopy, Dr. Manjula Nani, talking on the viral topic of robotics in gynecology, and my dear friend and batchmate, Dr. Rajesh Modi, who is spreading his reach from endoscopy into infertility, and therefore he's combined it as endoscopy and infertility, and has got an excellent group of faculty to give their real world experiences and practical pointers for the benefits of the delegates. Once again, we strongly believe that this collaboration and other collaborations that AMOGS has is growing from strength to strength. And I think that is the way we can spread the message of OBGYN care across the country and beyond. And I'm indeed thankful once again to be here this evening. Thank you all.
Thank you. Thank you, Dr. Ramaya. Rohan?
Yeah, madam, I won't take up too much time. I'm just grateful that we're being able to do collaborative programs. And in the theme of collaboration, we had AI and healthcare last time. This time around, we have I should say, the symbiosis between the endoscopic surgeons and the infertility specialists. And I'm looking forward to the educative programs. I think the talk on robotics as well as the panel discussion is really going to bring out key points which are going to help in the key day-to-day practice. And I'm grateful to TNFOG as well as the entire AMOGS committees in order to take this collaborative efforts ahead. So I wish everyone a very fruitful learning, and I'm really grateful for our chief guests and guests of honor for coming ahead and giving their words of wisdom as well. So thank you very much.
Thank you, Dr. Rohan. Now we'll go with the blessings from our chief guest. Can I have the CV of Dr. Jaideep Tang, sir? Dr. Jaideep Tang is the past president of Foxy, and of all this, he needs no introduction. He is a best human being and mentor, as Ramaya sir was telling. Jaideep Tang was the chair of the Young Talent Committee, and he has the project led the Foxy and the USAID project, and Secretary General of Foxy from 2018 to 21, awarded the FR Shivaji honorees, and past president of Mumbai Society, and he has many committee chairs in AMOGS and FIGO committees. He has many publications and consultant in many hospitals, and Sir is very famous for his Atuna project, which is going very well throughout India. Jaideep sir, thanks, sir. Stage is yours.
Thank you. Thank you very much, Dr. Sampath Kumari, for those very, very kind, very warm and very generous words. I have, of course, known Dr. Sampath Kumari for so many years. And I still remember during COVID, Dr. Sampath Kumari and TNFOG did so many webinars, and I was always very, very happy to be a part of them. And it's always a joy for me to attend anything organized by Dr. Sampath Kumari, and I would like to wish her all the very best for all her future endeavors. It is great to see two state associations collaborating over here, the TNFOG and the AMOGS, both very close to my heart. And I would like to congratulate the president, Dr. Amla Devi, and Dr. Sampath Kumari, the secretary, In fact, I would just go one step further and say that I'm always very partial to secretaries, because even in Foxy, I was Secretary General for 3 years and I was President only for 1 year. So obviously, it means that I spent much more time being a secretary than being a president. Congratulations also to Ameya and to Rohan for all the wonderful work they were doing. And thank you, Ameya, for the very kind words. It's a pleasure and a privilege to be a chief guest alongside, again, someone whom I have known for a very long time, dear friend Kalyan, who is the VP elect of Foxy and the immediate past president of the IIG. And we hope that Kalyan, one day we will see you soon in a position of political power, if I may say so. Very
Thank you,
soon,
sir.
you will be of immense help to our entire fraternity. And of course, the guests of honor, Dr. Amla Devi and Dr. Anjalakshi. Again, I have met Dr. Anjalakshi so many times, and it's always a pleasure to see. I would also like to thank the conveners, Dr. Sampath Kumari, Dr. Pradnya, and Dr. Madhumita. And I'm sorry I took a little extra time in joining. I was just wrapping up another meeting. And I must admit that the topics that you have selected are excellent, and the speakers that you have selected are perhaps the leaders in their fields. Dr. Asha Rao and Reddy are going to be the chairpersons for the first session, where Dr. Manjula is going to speak, and we all know what a fantastic speaker and a surgeon she is. We're looking forward to hearing from you. And then you have a very interesting panel on endoscopy and infertility, where Rajesh is marrying his interests of endoscopy and infertility. And Rajesh, of course, leads the Dr. Modi Pluro Clinic in Nagpur and in Akola. He's also the president of the Akola OBGYN Society. And I would say that he's one of the very few people who is extremely articulate even while he's operating. And it's a pleasure always to listen to him. And absolutely wonderful panelists, Dr. Saravana Kumar, Keshav, Monica, Dr. Sundar, Amo, Dr. Vanita, and Dr. Manoj. So all in all, many congratulations to TNFOG, AMOGS, and all the leadership and all the conveners for putting such a fantastic program together, and wishing all the very best for all the future programs. Thank you.
Thank you, Dr. Jaydeep, for the nice words. Now, can we have the CV of Dr. Kalyan?
Yes.
Dr. Kalyan Bamde, all of us know about him. He was the past president, IAG president, and he is the vice president elect. And so he has served for the Foxy and IAG with many designations. Vice President IMA Maharashtra and Joint Secretary IMA and Chairperson of AMOGS Infertility Committee. And he has a lot of books in his edited many books in the Foxy and awards and felicitation a lot. Now
Thank you
we'll
so
go
much.
to Dr. Kalyan. Yes, Dr. Kalyan.
Thank you, ma'am, for this nice introduction. I first of all thank all West Zone leaders for making this possible in the history for the first time that unopposed vice president election has happened. And it's great to see collaboration of AMOGS and TNFOG. I thank TNFOG President Dr. Amla Devi and Secretary Dr. Sampath Kumari Madam. AMOG's president, Dr. Amaya Purandare sir, who is the gem of a person and academician, and Dr. Rohan Palshetkar, who is our darling in the AMOGs. And chief guest, Dr. Jaideep Tang sir, nothing to say about him. He's the mentor for all of us in Foxy. And from my first post, he has mentored me for all the Foxy activities till date. And I am thankful to him as well as Dr. Amla Devi, Dr. Anjalakshmi Chandrasekhar. Topics for today is robotics. As a lab surgeon, I like to say Dr. Manjula is an excellent robotic surgeon. Robotic surgery is advanced evaluation of traditional laparoscopy, and a person is sitting in the console in a good comfortable sitting with controlled wrist movements, 3D HD monitor, enhanced precision and dexterity. That is what is required in today's world. We need to learn new modalities like robotic, Laparoscopy is guru of everything, but robotics is the future. And I wish all the best to Dr. Rajesh Modi for taking a panel on laparoscopy in infertility, and all the best to the future endeavors to Dr. Sampath Kumari Madam and Dr. Madhumita for their future. I thank all TNFOG team and AMOGS team for inviting me for giving few words in this webinar. Thank you so much.
Thank you, Dr. Kalyan.
All the best to you, ma'am.
Thank you. Thank you. With all your supports, everything should go well. Anyway, we'll go with the next guest of honor for the few words, Dr. Amla Madam. Amla Madam is the current president of TNFOG, and she was the president of the Dental Society, and she has written many books and faculty in many conferences. Amla Madam, few words. Madhumita, Amla Madam இல்லையா?
Ma'am is there. Ma'am is muted. Amala ma'am.
Now, am I audible?
Yeah.
Yeah.
Audible.
Good evening to everybody. This is a very pleasurable moment for me because this is the first time I have taken over the charge as the president of TNFOG by the guidance and gift of I use I should say that I should thank Sambat for giving me this opportunity, and this is joining with AMOGS and TNFOG with a galaxy of experts. The chief guest, Dr. Jaideep Tank, Dr. Kalyan, and the other Dr. Ameya Prundre and Rohan Balshekar, and all the other speakers of session 1 and moderators and the panelists of all the today's program. Actually, it is two types of different committees. No, that is, one is the sexual medicine committee, and the other one is robotic and endoscopy committee. That is two different separate types of committees joining together, and including us also TNFJ also. I think it is just because of Sambat this has happened. I wish her all the best, and I request everybody to support her during the election. This is our main request during this webinar is not only participating or being a guest of honor. This is my humble request to all the participants to support her for this election. So
Thank
all
you.
the chairpersons,
Thank you.
everything. I once again I give you my thanks to everybody who is joined here. Thank you so much.
Thank you, Amla Madam. Thank you so much. Next, we have our Dr. Anjalakshi Madam. She was the past TNFOG president, and she is the founder president of TNFOG and past president of OXY. And all of us know she is the dawn of diabetes. Her PhD of topic only now we are doing with GCT as she was working with Seshaya sir. Anjalakshi Madam, few words.
Thank you, Dr. Sambat. Respected chief guest, guest of honor, my co-guest of honor, Dr. Amala, and distinguished faculty and my dear delegates. It is a privilege and honor to be part of this CME focused on robotics. Robotics, it represents the beautiful integration of medical expertise, technology, and innovation. It has expanded the possibilities of minimally invasive surgery by offering enhanced precision, improved visualization, and better ergonomics. And the ability to perform the complex surgeries like surgery for the advanced endometriosis, oncological surgery, and gynec benign surgeries and fertility preserving surgeries. The CME, it can provide a platform for for us to learn and exchange the experience and also to understand the advantages and the limitations. I appreciate the efforts of the organizers for joining or collaborating with the AMOGS and bringing together the experts, and I wish the CME a great success. And today's discussion is going to inspire all of us to move towards a safer, smarter, and more patient-centered surgical care. Once again, I thank the organizers for giving me this opportunity and my best wishes for the CME and my best wishes and success for the Sambat Kumari in the coming election. And I request all the AMOGS people also to support her so that she will come with the flying colors. Thank you very much. Jai Hind.
Thank you so much, ma'am, for your blessings. I think Sampath ma'am, she's in Ahmedabad. I think she's held up. Sampath ma'am?
Is not there, I think.
Yes, ma'am. Ma'am is there, but I think ma'am is muted because she's in Ahmedabad.
Madhumita, I think you can introduce the chairpersons and we can start with the first session.
Yes. So moving on to the first session, we have a very interesting talk on robotic in gynecology by Dr. Manjula Anagnani. And it's my pleasure to introduce our chairpersons, Dr. Asha Rao ma'am, who is a director at Rao Hospital at Coimbatore. Ma'am is also the past chairperson of Endometriosis Committee of FOXI and past president of Coimbatore Obstetric and Gynecological Society. And ma'am has organized various conferences, and she's queen of endometriosis, I would say. And our next chairperson, we have Dr. Riddhi Desai, who is a consultant endoscopic surgeon at Mumbai. She's also the managing committee member of AMOGS and also the chairperson of robotics and endoscopy committee of AMOGS. Over to the chairpersons, ma'am, to introduce the speaker.
Thank you, Dr. Madhumita.
Yes.
For your kind words. And at the outset, let me thank Dr. Sampath Kumari for having invited me here as a chairperson. And I congratulate the team on having organized such a fantastic scientific session with all the stalwarts from Maharashtra and Tamil Nadu. And I'm glad to meet today all the stalwarts, past President Dr. Jaideep Tank, and all my friends, Dr. Ameya, Dr. Kalyan Bermade, Dr. Rohan, and my dear friends from TNFOG, Dr. Amala, Anjalakshi, and the galaxy of young surgeons waiting for the panel discussion. And now we have Dr. Manjula Anagani to speak to us on robotic surgery. And everyone knows Manjula. She's a Padma Shri, and she's also the Guinness World title holder for removing the highest number of fibroids in a single operation. And Director of Women and Child Unit, Chief Gynecologist and Obstetrician and Laparoscopic
Asha.
from Maxter. And she's such a charming and efficient surgeon.
Yeah.
And let me not stand between the speaker and the talk. But at the outset, let me wish Dr. Sampath Kumari all the very best for her journey. I'm sure she'll be successful. All the best, dear Sampath. And I present to you Dr. Manjula Anagani.
Thank you, Dr. Asha. It's actually a pleasure. Can you all see? Right?
Yes. Yeah, you just have to enlarge the slide.
Yes. Right. So it's a pleasure talking to you, and I really want to wish Dr. Sampath Kumari all the best for her upcoming whatever which should be, it is a political thing. So today I thought this is a topic which is very, very important to know, that anything which comes to the world, Indians are the first to adapt and first to take it, whether it is cell phone or whether it is a number of cars which we have in Hyderabad, or even, like I say, even a beggar will have a cell phone. So is it really necessary that we should have a robotic in our thing? And if we don't do it, are we somebody who is lagging behind in our prowess or something, which I thought we should be talking about? So there are always two camps in the OR. It's the same thing. I can do anything with laparoscopy. So why should I go ahead and do a robotic thing? So is it the future, really the future? Why, in what way the cost is going to come in the way? And why should I subject the patient for the cost effectiveness, which is not proven it? So it is definitely, is it the repackaging of laparoscopy without any proven survival or major morbidity benefit? Or does the RCTs actually show any difference between conventional laparoscopy or benign hysterectomy? Does this cost, capital, disposable, maintenance, all these costs and the marketing costs are going to actually fetch something? But what we need to understand, like Dr. Kalyan Barmade has already said, is a genuine clinical need, is a 3D vision, rested instruments, tremor filtration to these patients who would otherwise need an open surgery. So the learning curve is very less. So more and more surgeons can actually adapt to this. And decisive actually in the difficult situations like obesity, large uteri, deep endometriosis, and complex pelvic construction. And yep. How do we actually settle this question? So let us take it into 4 different sections. One is origins, promise. How did we evolve into robotics in today's time? And what does the evidence tell us? The hard questions about benefit and ratio of outcomes versus benefit. And what changes next? What does the future have in hold? So origins, the robotic did not just come overnight. It did not come out of vacuum. So to judge whether it is necessary or not, we need to understand in pre-1990s, it was open laparotomy. When we were in MBBS, it was open laparotomy for everything. We had excellent exposure, retractors working, tactile feedback. The price was less, cost effective, patient had but long stay, incisional hernias, wound infections, morbidity, and the cost in the form of family support, which has to be there. That was there. In 90s, early 90s, I was doing my PG. That's when the laparoscopy came, which really made my life in a different angle because I went into laparoscopy. The early users always have the advantage over it. Smaller scars, faster recovery. It became standard of care in 2000s, where more and more people started understanding the importance of it. Even the surgeons started learning. Even the patients wanted it. So it was a demand and supply. So he had a straight stick, the rigid instruments, and the steep learning curve. In 2005, the first time Da Vinci FDA approval came. Like in our obstetrics, we have a latent curve, latent phase, and an accelerated phase. 2 decades it took for the accelerated phase to come, 1.5 decade. So it had the 3D visions, the surgeon seated in console, but 2014, say almost a decade later, you had other things which came competitors because in 2024, in 20s, Da Vinci has lost its patency. So other companies have started coming. So basically, the recurrent bargain is the tactile feedback, cost, simplicity has been bargained over for precision, flexibility, and dexterity. So robotic is the newest instance in the last 50 years which has come. How does it actually work? It is a master-slave telemanipulator. We are the masters, we tell what it do, and the slave does it. So it is not something, it is not liable for anything. If anything goes wrong, we are liable. So we tell what to do, and it is us doing what we are telling. It is just relate to that. So we are sitting in the surgeon console with an ergonomically better way. We have a magnified 3D field and we drive the instruments into it. And the patient side cart is one which have 3 or 4 docking instruments, scope, 3D scope. And you have an assist system where your best assistant is going to stand there. Vision system, which shows a high definition. Then the endorist instrument, which has a completely fully wristed 360 degree, 7 degrees of freedom and 360 degree rotation. So what does this debate actually comes? Until very recently, the surgeon felt nothing, no haptic feedback. But now the more future is that we are going to get the feedback of it. So that is going to change the whole scenario. So what the platform actually adds is 3D vision, yes. Wristed instrument, yes. Tremor filtration. So all of us want to operate until we die. That is in 60, 70, when we still have the tremors which are coming up. The experience of ours to be translated into the, along with the evidence, to the best outcomes for the patient, it is the tremor filtration which is important. That's where we look at ergonomics and tremor filtration. And what happens, I will just tell. What happened? Once we said, okay, robotics came, it has the fastest growing route. It has become the second common robotic operation, that is a robotic hysterectomy. From 75% in gynae oncology, laparoscopy, minimally invasive surgery has come down 41% because only in endometriosis we start doing it. Whereas when it comes to CA cervix, the MIS has come down to literally 0. And there is a higher intervention cost of 25% when we are doing robotic. So in oncology, in gynae oncology, it is only in CA endo, which we are doing, or early CA ovary. But otherwise, rest of the onco, we do not use it. And only the benign surgery is more and more we are being doing it. Is it right or wrong? So why is this change? Is it the demand of the patient, or because we are having a FOMO of we are not doing it, somebody else is doing it? Is it the need of the patient or the case or the surgeon? The case needs it, so we are doing it. Or is it the new kid, so we have the enthusiasm to do it, or the aura of being called as a robotic surgeon? Or the technical difficulties of lap is pushing us towards it. What are the actual benefits to lure us? Then what happens to the cost? If there is a closed console, what happens to the ergonomics to the neck? Is it a space-occupying lesion inside the OT? The learning curve is relatively less, but it's still there. So what are we going to do with it? Whatever said and done, 87% of laparoscopic surgeons will have physical symptoms or discomfort. 87%, staggering number. Strongest predictor of symptoms was high case volume. The more you do it, the more ergonomic damage. High rates of neck, hand, lower extremity symptoms, and it is strongly associated with high case volumes. So how do we address it when robotic? If you have a limited depth perception, the 3D magnification will help it. Endoscope is held by assistant. You can shout at them when they're not showing well in laparoscopy. Whereas when you are holding the endoscope, you know where to go and you cannot shout at yourself. And reduced dexterity, additional arms, and decrease of freedom will help in robotic. I love the fulcrum effect. What do I mean by that? The fulcrum is at the abdominal wall in laparoscopy, so the pain score is still high in laparoscopy. The fulcrum is at the wristed instrument, and whereas abdominal wall, it is stable. Because it is stable, the pain score is very, very less, literally 0 to 1. So for patient, it is a pain score which is important. For us, it is tremor amplification, which is filtrated by the robotics, and ergonomics, which helps us as a surgeon. And for the surgery itself, it is a flexibility, dexterity, and the, like I said, flexibility, which will come. Precision. What does the evidence say? It's okay to say anybody who does laparoscopy will say that laparoscopy is the best. Anybody who does the robotics will always say robotic is the best because we have it and we can promote it to the patient. So is it the marketing gimmick, or is there evidence which say according to the indication? So it is a case-based. So let me take you all and show you what is the advantage with the robotic and what does the evidence say. So when we go, you can see the precision with which we can have a thing, and so lateral thermal damage is least. So you can go the way the armed wrists go, and we can cut it as a knife when it comes to UV fold, or when it comes to any ligament which we are going to cut. You can see the blood loss is almost nil. It will be maximum of 5 cc when you do it with the precision with which we do. And the robotics helps us in the UV fold and the way it goes over the vaginal tube. And once you know, the instrument tip is only 3 mm, not the 5 mm which we have. And even though the proponents say it is unipolar, using it in the 3 mm unipolar is like a knife. So that lateral thermal damage is negligible, and if you use it as a knife, your cuff dehiscence is also lowest, and when you suture it with the barbed sutures in 2 layers, you will not have any morbidity or even any complication. You can see the ease with which it goes, and the suturing is the main thing. I will show the suturing in the myomectomy. So what does the evidence say about hysterectomy? The trials are tight. There is no clinically meaningful difference when it comes to hysterectomy. Major complications are same. Conversion to open is little lesser in robotic. Length of the stay is same. Blood transfusion rate is the same if at all it is done. So the verdict on routine benign hysterectomy, straightforward hysterectomy, is definitely old wine critic. That is what we have to remember. But that is the highest utilized in the robotic surgeries as of today. So what I actually say is that what evidence is different, what exactly from the patient point of view in today's time cost does not hold true because everybody can afford. So let us see what does it say about myomectomy. So myomectomy, it is the same thing what we do in open, we do it in the laparoscopy. What we do in laparoscopy, we do in the robotics. So first is always the installation, that what we do is installation of the vasopressin, and the oblique incision using the monopolar scissor is what we use. Look at the way it cuts, hardly any, literally zero bleeding is what we see. Like I said, the precision and with which it cuts is like that. And we can use the assist port and myoma spiral into it, or we can use a tenaculum or a cardiac with it. And we can use this the monopolar cautery to just cut the additional tissue which comes and remove the whole with the scooping technique or holding technique, or we can always say a grabbing technique. We can just cut over and take over the whole of the myoma till the base, and then the myoma bed, I would just say, and keep it aside. Now, what we need to understand, the suturing is what holds true when it comes to the robotic. So it is just like what we do. I usually say it is like sari draping technique. You just go inside, come out, go inside, come out. And it is just like doing it with the open hands, fingers. You just have to go hold it with fingers. It's like an open technique, how you do the same thing we are doing in a robotic. But we need to understand myomectomy is a hybrid technique. So till here, even though we do it, morcellation is still done for the contained morcellation is still done in the robotic also. So this one technique, even though it is benign, laparoscopy is again coming in when it comes to the hybrid technique. So you can see the myoma bed, even in 3 to 4 layers, we can suture without the ergonomics help damaging us. And the complete, it is not too tight to cause necrosis and not too loose to cause hematoma formation. So you can have a great sleep in the night because we are not worried about the hematoma or hematoma. So this is the way it will go. So when suturing skill is the whole game, it is a myomectomy is about reconstruction. So fertility sparing reconstruction, this has an edge. It reaches the complex cases like cervical, fibroid, and any nook and corner in the broad ligament where it goes too deep into the lateral broad ligaments, lower blood loss than open. The honest counterweight in this is myomectomy suturing skills definitely holds a robotic health thing, but no proven advantage in symptom relief or recurrence because it's the same thing what we are doing. Power morcellation is still there. It's a hybrid procedure. Then what happens in the endometriosis? This is one case where, especially in the DIE, where robotic have a higher edge when it comes to whether it is a bubble or the shaving, or you see with precision with which we can separate the broad ligament. The pain of endometriosis is definitely because of DIE into the broad ligament. And the way we can just take out the layer of broad ligament, that is butterfly peritonectomy or deperitonization, is something we can do with precision with the monopolar scissor. But everything is about expertise. No instrument or anything is the god. It is the man behind the machine, and it is us. We have to learn the exact technique and then go ahead and remove every bit of exercise, every bit of endometriosis which is there. So I will go a little faster here so that I can show the whole of lateral peritoneum is being removed. Then on both sides. So once we see the uterosacrals, be on the medial of the uterosacral, never go lateral to the uterosacral, and then separate the pararectal and prerectal spaces, and then remove the rectovaginal nodule. And here in this case, even the anteriorly, everywhere surface endometriosis is there. Only the layer with precision, we can be removing it. We don't have to worry about the vasopressin or giving the vasopressin or taking it out. So endometriotic cyst, the advantage in robotic is that the exact the layer, the differentiation can be made, and we don't have to be taking out precision. You can see here the ease with which the plane is got in robotics, which we need vasopressin when it comes to laparoscopy. So with endometriosis, DE, shaving, or rectovaginal nodule, it is definitely the robotic which has an edge. With adenomyosis, we can do a myolysis. So precision in hostile anatomy, controlled dissection, ureterolysis, nerve sparing, bowel, bladder shaving, stamina for long cases. This is where definitely for a dog surgeon, this has an edge. But again, comparative trials do not show clear superiority. It is a platform which is second, expertise which is the first. So it is the man behind the machine. Then comes sacrocolpopexy. This is where, again, definitely laparoscopy versus robotic will have an edge. This is the Y-shape mesh which we are preparing. And I will go a little faster in this. And once we separate the peritoneum anterior posteriorly, we are going to anchor the mesh onto posteriorly first. I always take posteriorly first so that anterior leaf can just fall on anteriorly, and it is much more easier for us to suture in laparoscopy. So I'm just showing a laparoscopic sacrocolpus suspension. So we are finished anchoring the posterior, then anterior. So then we open the lateral broad ligament and get it above, and then onto the once we see the anterior longitudinal vessel there, buzz it, separate it, and look at the longitudinal ligament, and onto it, onto the promontory is that place where we go and use the tacker to put the mesh. So this is where we can avoid tacker and use suturing. And we can, this place where it is technically difficult, robotics has an edge. So once we finish this stacker, then we go ahead and cut the extra mesh and take it out. 3 tackers is what we do, and close the thing between the peritoneum is closed. So comfortable fit, minimally invasive definitely beats the open. Robotic versus laparoscopy, the results are comparable, but ease with which we do the deep suturing and mesh fixation is definitely better. We shorten our operative time with robotics. So the cost premium, early operative time is what is important, but otherwise when the stakes are about survival, when it comes to gynae oncology, nothing beats survival. So just because it is the lowest morbidity, minimally invasive surgery cannot be done for CA cervix with all the LAC trial coming. And again, we are talking about laparoscopy in it, but I still feel that for cervix, let us leave it to the oncosurgeons, open surgeries versus radiation, with outcomes being same, because it's expertise which matters. We cannot help even the one patient who are going to have into morbidity. So lower surgical morbidity, sentinel lymph node mapping, safety is indication, which is simple. And it is the engineering advantage, is never the oncological license. So when it comes to CA endometrium and PLND, this holds the best outcome. So hysterectomy, extended TLH is something which we can do as anybody can do. But then when it comes to PMD, you can see the ease with which we can open the lateral pelvic wall, and you can see the common iliac there. Then we are separating the common iliac, and we are just going parallel to the iliacs, and we can reach the bottom where we see the genitofemoral nerve, which is the lower end. You can see very clearly the white structure, that is genitofemoral nerve. On the medially, you can see the obliterated vessel, ureter, and everything. And we remove the pelvic lymph nodes with this is sentinel lymph node. So we just took out one lymph node, and then we sent it for the sentinel lymph node biopsy. And then we have greenfly technology, where we can take out exactly which lymph node to be taken without anything. Even in the total pelvic lymphadenectomy, it is much more easier for us to remove the whole lymph node in toto when it comes to CA endometrium. So I believe laparoscopic surgeons and robotic surgeons have an edge over gynae oncologists who can do a open surgery when it comes to the pelvic lymphadenectomy. So this is the way we do. And reassuring case is definitely lap and lace. Trials have shown is non-inferior to open, and robotics conversions will be less, especially in high BMI, because with CA endometrium, we have high BMI. We know the corpus cancer syndrome, and survival is equivalent. So why is this best platform is the best for oncology? The precision with which we can go into the lateral pelvic wall, flexibility with which we can go, and the dexterity we can use, and conversions will be less, and the morbidity is the least. So when minimally invasive cost lives in CA cervix, I think we should just leave it. Endometrial cancer is reassuring, and within the MIAS, robotic versus laparoscopy, survival is similar, but if possible, robotics is better in them. The hard questions come. What is the initial cost? Per case disposable, service and contracts. But cost is not destiny. In today's time, when the alternative is open, definitely robotic or laparoscopy hold good. And the patients are ready to afford it. So if we are in the 2-tier or the 1st-tier or the cities where the hospital has it, we should be using it for the case. So it depends on the comparator. If somebody is an expert laparoscopy, they can always say that it's an additional cost and it is not much of a gain to them. But when it is versus open, robotic has a higher say, cost neutral, it has to be there. So high case volumes will decrease the cost. So it is definitely worth it, and it needs needed. So it depends on high case volumes and the type of cases we are going to think. Learning curve is much better. Many surgeons will do it, but we have to do a simulation first. Proctored dual consult, credentialing, and volume is important. So for us, it is a precision, flexibility, dexterity, rated visualization, ergonomics, tremor filtration. Learning curve is less, teaching is easier. For a patient, it is stability of ports and less fumes. Pain score is the best, faster recovery, reduced infection, blood loss, transfusions, shorter hospitalization. So this is the various studies which came up for post-operative pain. When we started seeing our own study with the patients, the pain score is 0 to 1. So comparable overall. Then the caveats is like vaginal cuff with robotic is much more lesser, because it is a 3 mm instrument and 2-layer barb suture is what we use. Steep Strindlenberg People always talk about it. So if the patients are, if the lung function tests are, PFTs are good, and we take care of careful padding, time limits, neuroplastic injury can be avoided, it is good. Loss of haptic feedback, but we can judge it visually. We need to understand that the future is there where we are going to get this, and access and device events is something which is, we should immediately turn. Docking and undocking is something which the team has to change. So it is basically a technique and training sensitive. So where robotics genuinely earns its place is when their woman is obese, deep endometriosis, large or fibroid uteri, democratizing the MIS where many surgeons can start doing it because it is much more simpler to adapt to the situation. So who actually gets the new bottle? Because high income technology, so where high volume centers are there, that is where this has to be there. It has a limited reach in the countries where resources are an issue, but equalizing forces is what we should be looking at. So when it becomes affordable, that should be the way we should look at. What changes the answer is many more companies are coming forward. So we are looking at decreasing the cost so that we can offer to the patient as a lesser price, and more of robotic single port, robotic V nodes and beyond is coming to avoid the incision. I think it is the expertise which will take us where we are going it, but it is early to talk about it. Console is a data platform. So everything is about AI right now. So we talk about everything being data being adapted, adopted, put in the thing. It is for computer vision. It is about that data I can analyze myself. I can share with my peers. I can share when I want to teach. So it gives us a feedback saying that where we go wrong. And future is going to be the virtual, where it is going to map us where the ureter is going to be there so we can avoid injury. So bounded autonomy is what we are looking at. So it is remote proctoring. Now we know everywhere from India also teleoperating is happening. It is proving. The promise is expertise without geography. The real hurdle is the engineering, where is the 5G there, is the 6G there, network latency, regulation, and liability. It is promising, but not at routine. So neither slogan, it is old wine, is right, nor the need is right. It has to be the individualized thing. Routine benign hysterectomy, no clear benefit. It only adds time, but enthusiasm. But when I say adds time, in our case, it is not adding time because we hardly take 15, 20 minutes for even robotic hysterectomy. So I think that with expertise comes how fast we can do. The need is definitely in obesity, large uteri, deep endometriosis, prolapse repair, validated and valuable for CA endo, lowers the barrier so that many surgeons can come. So resolution should be the right tool for the right patient in the hands of the right surgeon and with the proper indication. That is what we all have to think. So is it the old wine or the need? It is equivalent, not superior for routine cases. Adoption should be depending on indication. Real value lives in hard subgroups. Cost and access is the swing, and depending on your patients who take it. Thank you, and thank you, AMOGS and TNFOG, for giving me this opportunity. Dr. Sampath Kumari, thank you for giving me this opportunity.
Madam, that was a phenomenal talk. I think it was a true delight to listen to you. You have given such an unbiased opinion. You have covered everything, all the aspects of robotics versus our routine laparoscopy. And I think truly robotics is here to stay, definitely has an edge in advanced cases for sure. And I think your talk was such a reflection of your own expertise. Videos were a delight. Absolutely fantastic videos.
Thank you, Riddhi.
Truly nice, madam. Thank you so much for that wonderful talk.
Thank you.
Asha, ma'am.
Yeah, lovely talk, Manjula. Really enjoyed.
You,
my anxiety is always how to make it work for the Indian patient who earns 10,000 rupees a month.
True.
That's only
I agree. But I think more and more systems are coming.
I'm sure the surgeons are enjoying all the comforts, Truly painless for the surgeon also. Right. That's what Damodar always says.
Yeah. Hybrid is also coming, madam, where one arm can be robotic, rest all can be laparoscopy. So I think we'll wait for that to come.
Yeah, I'm sure, but the time will be the answer. Yeah. Yes. Enjoyed your talk, Manjula. Thank you,
madam.
Thank you so much, ma'am. And just before I hand over, I wanted to place on record my gratitude to Amay sir, Rohan, Dr. Sampath Kumari ma'am, and best wishes to Sampath ma'am for her elections. And a big thank you to my friend, Dr. Pradnya Supe, for giving me this opportunity. And of course, thank you to Dr. Madhumita, the convener of the program. Thank you so much.
Thank you so much, Dr. Riddhi. Pleasure to have you today with us. Thank you, Manjula ma'am and Asha ma'am and Dr. Riddhi for the wonderful first session. So we move on to the second session. Pradnya ma'am, you'd introduce Rajesh Modi sir.
Yes, thank you so much, Madhumita. So for our second session, we have a panel discussion on endoscopy in infertility. Our moderator is none other than Dr. Rajesh Modi sir. Sir is president of Akola OBGY Society. He's a gynecologist, robotic and endoscopic surgeon. I don't think he really needs any more introduction. Moving on to our panelists. So our first panelist is Dr. Sarvana Kumar. Sir is President OG Society Salem, Tamil Nadu, past Treasurer TNFOG. We are so honored to have you here with us today, sir. Our next panelist is Dr. Keshav. He's Managing Director of Ashwini Maternity and Nursing Home, Panvel. He's a visiting laparoscopic surgeon at Shatabdi Hospital, Govandi. Also honorary visiting laparoscopic surgeon at Sion Hospital, and also my senior. So welcome to have you here amongst us, sir.
Thank you.
Our third panelist is Dr. Monica Umbardat. She is consultant OBGY at Mangalya Nursing Home, Atharva Fertility Center, chairperson of the PSA Committee of FOXI 2026 to 28, national coordinator of the PSC Committee from 23 to 25. Welcome here, Dr. Monica. Our next chairperson is Dr. Amog Chimote. Can I please have a slide? I think he's not there. So he's a fertility consultant from Nagpur and also operating faculty at Kiel School of Gynecology and Endoscopy. Next, please. He has said he's just joining, so I'm hoping he will be there. Dr. S. Sundar Narayan, sir, is gynecologist and fertility specialist at Fertility Center, Nagarkoil. He's also the chairperson of Endoscopic Committee of TNFOG, past secretary and vice president of Nagarkoil OG Society. Welcome, sir. We have Dr. Vanita. She is Medical Director, Sunrise Laparoscopic Center, Ashok Nagar, Chennai, Coordinator of the South Zone Foxy Endoscopy Committee, Advisory Committee Member of OGSSI, Joint Treasurer of TNIAG, and Teaching Faculty at ESIE, Chennai. And we have Dr. Manoj Aglave. He is Consultant Laparoscopic Surgeon and Fertility Specialist at Siddhivinayak Hospital, Lakhani, Bhandara. He is ex-assistant professor at IGMC Nagpur and secretary of Bhandara OBGY Society. So welcome, Dr. Manoj.
Thank you, Pradnya.
Yeah. Dr. Modi sir, you can please start.
Thank you so much. Am I audible clearly?
Yes, sir.
Yes.
So thank you, Dr. Sampath Kumari, madam, for this wonderful opportunity, and my best wishes to you for the upcoming Foxy presidentship elections. And Dr. Madhumita also, thank you for involving me in this particular session. So we will quickly go on to the panel discussion. We are going to be talking about various aspects of endoscopy related to fertility enhancing surgeries. And there are different aspects from which I would be requiring the input from all our esteemed panelists. And I welcome all of you, the panelists, also to this particular discussion. So one of the commonest aspects nowadays, we're not going to go too much into hardcore endoscopy, but endometriosis is something which is becoming very common as far as fertility and endoscopy is related. Let us focus on ovarian chocolate cysts. So from the perspective of being able to operate on a cyst, so I hope you are able to see the video which is coming up. Bilateral chocolate cysts are very common nowadays. So do you have any particular way of surgery where you recommend or you do not recommend the way the surgery has to be done? Let us start with Dr. Vanita. Or anybody of you from the panelists would like to take this part. Like this is just a video which I'm running. Yeah. But I would like to know, give some inputs regarding how do you deal with chocolates? Is any particular tips that you would like to give? Yes, Dr. Keshav.
Yeah.
So what we do is nowadays, whenever we see bilateral chocolate cysts, we know that there would be some element of DIE also involved. So that should be kept at the back of the mind at which center you are going to do such cases where there are bilateral endometriotic cysts. Then, as we know now that first of all, we start with our dissection and at the sigmoid level, separate those adhesions. And when you know that you have an endometriotic cyst, a few things that help us are dissect the plane properly, be slow and steady. We can use vasopressin. We can sometimes instill it in the uterus itself or near the infundibulopelvic ligament, so as to reduce the oozing which is interfering. And then we enter the right plane, as we know, so that the use of cautery is reduced as much as possible. So that helps us in giving us the edge over reducing the ovarian reserve, and also stay as much away from the hilum which and use of cautery there, so that if you, and there are these techniques where you can cut it right in the middle and then strip off the endometriotic cysts. So these are few things that we use in the endometriotic cysts these days.
Yeah, so this is something which I routinely follow, that we try to inject the vasopressin into the broad ligament, and this allows us to remove the cyst wall without any amount of bleeding or oozing on the ovary side. The purpose is to avoid using cautery on the ovarian tissue as far as possible. Dr. Amog, are you there with us? I think is yet to join. So, Dr. Sundar,
Yes.
give your input regarding one particular aspect. Now, once a cystectomy has been done, do you prefer to suture the ovary or do you prefer to leave it as it is?
Previously, I used to leave it as is, but I have come across a lot of situations, circumstances in which the whole ovum of the tissue gets stuck up to the ovary, which do affect the fertility in the future. And there is one thing, because the adhesions, there may be, supposing the patient is going for ART in the future, there may be some difficulty doing the ovum pickup and everything. So nowadays, I prefer to suture it, sir.
Okay. So, from
But
my perspective also, if the ovary is not very large or opened out, then we leave it as it is.
yes, sir,
But
if it is a
sometimes
small
what
sister,
happens
obviously,
is,
yeah.
if sometimes a defect is quite big, I have a habit of leaving 1 liter saline inside. So if I feel that if I'm leaving saline and the ovary is going to open up and float on the saline, then I prefer to take a purse string closure just to approximate
Yes,
the
sir.
edges. So, Dr. Manoj, do you have any particular input about any suggestion regarding preventing recurrent cyst formation? Because chocolate cyst is something where every patient is worried about recurrence. And even as a surgeon, even I get worried about recurrence of endometriosis or recurrence of chocolate cyst. So, any particular input that you have?
Hello.
Yes, we are able to hear you. Tell me.
In case of if you want to prevent the recurrence, we'll keep in mind while removing the chocolate seed, we'll try to remove strip that cyst wall completely, so that there should not be again the formation of the chocolate cyst in such patients.
Yes. And what do you feel is the role of post-surgery medication? What medication do you usually prefer, or it's not really required?
The patient is planning, if she's not planning for the fertility, or she doesn't want to conceive in the recent period, so we can add leuprolide injection for such patient.
Yes, that is quite commonly used. Dr. Saravana Kumar, I would like to ask you regarding the follow-up treatment for, suppose patient is mainly for infertility. Do you prefer to wait for some time, or do you prefer to induce the cycles immediately after the cystectomy for patient's conception?
So the conception after endometriotic surgery is best within the first 6 months to 1 year. Afterwards, probably the patient may be having a recurrence or probably adhesion formation. So I would probably go with the induction within the next cycle itself. So that will give a better outcome for the patient.
Yes. So quick output from all four of you as a panelist. How long do you recommend to wait after the cystectomy surgery for inducing ovulation?
Sir, I also go with Saravana Kumar. I don't wait too long at all. Actually, and I also don't prefer to give any antagonist in this particular case. Yes, obviously, if it is for only pain relief, then it is okay. But otherwise, it is for infertility, better to go for the stimulation as early as possible, sir.
Yes, Dr. Keshav.
Yeah, basically nowadays we have started using elagolix also as a molecule, and after they are suppressed for say 2 to 3 months, and we give stimulation, the results are better because they are round regulated, and then with induction, the quality also improves if you have done a complete job. So this is what we have seen lately.
Yes, even from my perspective, usually not particularly any ovulation induction, but we tell the patient right from the next cycle that they can, if they're planning to go for natural conception, they can go ahead. If I have to induce, then I prefer to wait for 3 months. I mean, let 2 cycles pass, that after the third cycle is over, then we specifically go ahead with the induction protocols to be followed. So this is something which keeps on happening, very common in endometriosis. Apart from the ovarian surgery, I would like to discuss with you related to the myomectomy, one aspect, and then we will move on mainly for hysteroscopic discussion, because there is a lot of infertility which can be corrected with basic hysteroscopy. So let's talk about myomectomy for the moment. Myomectomy is something which I have been very inclined towards the concept of not using current again into the myometrium. So we use a lot of vasopressin with saline, so that the blood is replaced with saline, and then we don't need to use current during the myomectomy. Specifically to talk about the query, I would like to ask Dr. Saravana Kumar,
Yes,
what
sir.
technique are you using to prevent the blood loss during myomectomy?
Sir, usually I give a vasopressin injection and hydrodissection, sir. Very rarely, sometimes if the fibroid is a huge one, and sometimes if it's a broad ligament, I may go for a uterine artery ligation at the origin. So those are the only things I do, and probably I infuse almost to 150 to 200 ml of saline with vasopressin, and that will beautifully dissect out the fibroid as we put the incision.
Nice. Dr. Sundar, what is your technique?
I am
Anything
also
different?
doing the same technique, sir. I prefer to use vasopressin with a huge dilution, so you can have a very good acute dissection. That is my preferred method. In case if vasopressin is contraindicated, then I may prefer to go for uterine ligation at the origin, sir.
Dr. Keshav, you have any preference of
Yeah,
any
so
other?
all our techniques are basically, we have learned it from you to use vasopressin liberally, diluted vasopressin. And also the irony of doing uterine artery ligation is it's much more difficult in the cases where the fibroid is actually very huge or broad ligament. So vasopressin, if you use with in coordination with the anesthetist, use them slowly initially. I think that's the best thing, because those oozers sometimes are not even stopped by uterine artery ligation, temporary ligation. The clean field you get only when you use vasopressin.
Yes. Dr. Manoj, what is your preferred way of preventing or reducing?
We are using this one vasopressin for reducing the blood loss. But if the fibroid is big and there is a more vascularity, then we can do the clipping of the uterine artery on the side of the at source, on the side of
Yes.
fibroid.
Now about the suturing for the myoma bed, I have a habit of using barb sutures. I would like to quickly ask all four of you, what is the suture material that you are particularly using for myomectomy suturing?
Barb, sir. Barb, sir.
Barb suture, yes. So now I think I would believe that it has become a very standard way to do suturing. It allows us to quickly close the wound without much of a struggle, and it holds the entire length of that tissue in place. So the tissue does not get loose, and the sutures are well positioned throughout the surgery.
So only
Still,
when we use sometimes the routine Vicryl #1 is when it's a very huge fibroid, 10, 12 centimeters, and you can take a box stitch anterior, posterior, and that
Yes.
base sometimes gets secured, and then you can suture it easily with the barb suture. So that's the only time we use the routine polygalactin.
Yes. Eventually, I always believe that the uterus will come back to its normal shape, how much ever suture or how much ever well or not so well approximation you have done. But eventually, the uterus at the end of 3 months or 4 months will come back to its original shape and contour. So rather than because of suturing, it is in spite of suturing, the uterus comes back to normal, is what I genuinely believe. So, what size of the uterus or what size or number of fibroids is your upper limit to do laparoscopy? So let's start with Sundar. What would be your cutoff?
It is depends on the expertise. I have tried up to about 12 to 13 centimeters, sir.
And
Beyond that, technically,
maximum numbers that you have removed is how much?
Maybe something around 13 or 14, sir. But
Good
they are all
number.
not huge fibroids. What I'm telling is multiple small fibroids. Sir.
Yes.
Yeah.
What about Saravana?
Sir, the maximum I have done is 5 fibroids, sir. And the size is almost 10 to 12 centimeters. I work in a medical college. I could be taking a lot of risk over there.
Yes. Manoj, what has been your experience?
Sir, I used to do myomectomy in the cases where if the fibroid is intramural, then it is the indenting the cavity. It might be because of 4 centimeter and above, depending on the size and
Yes.
cavity indentation. And
What
the
about
fibroid,
yeah. Continue, Manoj, please.
and if the fibroids are subserous, if they are not a much bigger side and not indenting the cavity, in that case, we are not go with the myomectomy for such patient.
Yes. Keshav, what has been your personal experience?
So we have removed sizes up to 14 weeks, but we counsel them that maybe we will require a mini lap incision for removing it, just suprapubic mini lap to remove it faster, to save the anesthesia time also sometimes. And the maximum fibroids I have removed are 14 to 15, where multiple small fibroids type picture, Yeah, but it's also certain types which are very hard, and the mobility. So all these things have to be taken into consideration. A good counseling session, like I say, in OPD is very important in endometriosis as well as myomectomy cases. You take time so that they are ready for whatever eventually it happens. Reduces the stress and pressure for you in the OT itself if you have a good counseling of the patient.
Very true. Even today, when I also have a patient, anything which is up to 24 week size touching uterus, I always tell the patient that we will do it laparoscopically or might do a laparotomy, depending on what is required for a better outcome. So for me, it becomes easy to tell the patient that, okay, if you're doing a laparotomy, it is because it will give you a better outcome from the future conception perspective. That reduces the stress for me if I have to convert it to a laparotomy. So even though I have been doing lap myomectomy for 25 plus years, even today there are patients who come and then I am very prudent for one thing, that laparotomy may be required. We do keep everything ready, as a drum is also ready for the laparotomy. Second aspect, very important, is recurrence. I never am able to convince the patient that we are going to remove all. It's easy to always tell the patients that we will remove the relevant ones, and not possible to remove everything because more damage is done if we are trying to fish out the smaller ones.
Also, so we need to counsel them that post-op also they could develop immediately, because sometimes we have seen that, they do a scan after 2-3 months and there are fibroids and they come back saying, "Arey, we just underwent myomectomy." So this part where a new fibroid can also come in, which is hardly 1 centimeter, but near the cavity and all. So these becomes a big thing when they are pre-IVF or for IVF, suddenly the cost and everything, they suddenly come to you.
Yeah.
It is always better to counsel the patient and take a consent for both, sir, before proceeding into a lap myomectomy. Better to take a consent for open surgeries also. I always do apprise the patient and take a consent, But we always tell them we will try to do it laparoscopically as far as possible. In case if we can't do it, then we can get it converted. But usually nowadays the conversion rates are very lesser compared to yesterday. Yes.
Yes, that is very true.
Yeah.
So from the perspective of recurrence, we always tell the patient that suppose I have a patient who has got 7 or 8 fibroids, I always tell the patient that, okay, you have multiple fibroids. The uterus has a tendency to make fibroids. So even if we remove the relevant ones, some seedlings, which may not be visible during surgery, which may not be visible on ultrasound, will suddenly get fresh blood supply and grow rapidly. So even in 3 months' time, when the patient sometimes will come back with a report of 1 or 2 centimeter fibroid, 1 or 2 places, we always tell that, okay, this is something which can happen. Don't worry about it. So recurrence is a problem in both, like you mentioned, in endometriosis as well as in fibroid. You have to be able to talk and discuss and explain to the patient. The next thing which we want to now focus on is a little bit of hysteroscopy aspect. Hysteroscopy is something which is very inherent for all infertility patients nowadays. And what size of hysteroscope are each of you using individually? So that is what I would like to ask you. What is the... Yeah, tell me,
2.9, sir.
And what about...
2.9, yeah.
2.9, sir. We are almost abandoned for scopes nowadays, sir.
What about Manoj?
But the only problem with 2.9 is that it gets damaged very easily. So I used to take the instrument outside, but nowadays I stopped using the instrument outside because it gets damaged so fast that I have to replace it.
Yeah, so like I said, no, I've been operating since 25 years. For me to change is not so convenient. I'm still stuck with the 4 scope. So 2.9 is available with me, but somehow, no, in my hand, it feels that the vision is a little better with 4 The main problem is not for diagnostic. Diagnostic does not make a difference whether it is 2.9 or 4 But mainly when we are doing the cannulation part, that is where I end up struggling because the 2.9, when you pass the catheter inside, the lumen is so small that the inflow gets obstructed. And unless I have a very clear flow and a good vision, it feels a little...
So that's struggle we also have.
Yeah. We also face the same difficulty, sir.
Yes, sir.
Especially with cannulation.
Cannulation.
And whenever using, at times with my French instruments also, we do have the problem.
Yes. So from that perspective, I have been having a personal preference for 4 mainly because I don't want that inflow to be interrupted. And every time I have tried the cannulation or any operative, even septum resection with 2.9, I think it gets stuck. The fluid inflow becomes a little compromised. Have you ever, any of you, tried to do hysteroscopy with only the inner sheath? Not about operative, about the diagnostic. Are you using it as a routine? A lot of people nowadays have started making the use of only the inflow, and sort of it becomes like an office hysteroscopy without
Yes,
any
sir, I'm doing it routinely, sir, that way only.
Only inflow sheath?
Only the inner sheath. It is a 2 scope with a 3.1 outer sheath, along with a, what do you call, operative channel also, sir, 5 French. So the whole diameter comes something around 3.4 or to 3.6, sir.
Okay. So anybody of you is dilating the cervix before doing hysteroscopy,
No,
or
sir.
are you?
No, sir.
What about you, Manoj? Are you dilating?
I'm dilating up to Hagar 7.
Yes.
Because many times we can create a false passage if we are not dilate. And prior to dilatation, I am giving a tablet misoprostol, 200 milligram by giant. Microgram by giant.
Okay.
The problem with giving misoprostol is sometimes I don't get the proper distension.
Yes.
So
Yes, that's the problem.
all the fluid gets out, and I have to use other instruments to hold the cervix. So I've stopped using misoprostol directly. If there is a difficulty, then probably I will dilate. Otherwise, I will straight away go with the flow of the fluid.
Yes, actually that becomes a problem. Over dilatation or a loose cervix. Suppose you have a polyp and then the cervix is already sort of opened out, then it becomes a different kind of a challenge to figure it out. Anybody else is using misoprostol as a pre-op?
Yeah, 200 microgram misoprostol we use per vaginally 2 hours before the procedure. But sometimes patient gets fever before operation because of the dose. Some patients are reactive to it, and also some have pain, spasmodic pain. So that is also something which is a discomfort. You promise patient that it's gonna be a painless procedure, and before the operation itself, they sometimes have these spasms which they complain of.
Yeah. Septum is another common procedure which gets done. What are you preferring, resectoscope or scissors?
Because I don't have a resectoscope. I only use a scissor.
Okay.
Still, you can use the look also. Bipolar look also you can use it, but preferably scissors, sir.
What about you, Keshav? Are you
So I use a resectoscope. Gubini's small resectoscope I've been using, which gives good coverage. So that saves me the scissor damage cost also. I feel in the long run, the scissors get damaged if it is very fibrous. If it's a small septa, it's okay. But some fibrous which are very thick bands, I don't think a good resectoscope is a must. I feel sometimes in septa.
Yeah. Scissors definitely becomes much more delicate and damaged. I usually end up using one complete scissors in one septum. So sometimes I end up breaking even two. If it is a broad septum like the one you are seeing on the screen, there is a possibility that I might end up damaging two scissors because I am using Indian scissors and they are not very long lasting. But then the cost is also not too much. It's a reasonably okay cost, and uh, affordability is not too much of an issue. But if you're trying to go in for a German scissors, then definitely the cost becomes prohibitive. Resectoscope, definitely sturdy, quicker, without any problem with blood coming in your field of vision. But from my perspective, even I have stopped using current in the endometrium cavity. Cold scissor allows better healing is what I perceive. But again, it's a personal choice. Both options are equally good. If you are using high current setting, then the damage is apparently less compared to low current settings if you are using a resectoscope. Any particular input you would like to give regarding septum resection about the technique and about how to decide when to stop? Dr. Sundar, kindly give some inputs.
Yes, sir. The one thing is always better to under resect than over resect, sir. That is one point of view. One point I want to emphasize. And another thing is, whenever you reduce the pressure, and if you started, some vessels are open, and if the blood is coming out, then I think there is a time you have to stop it. You can definitely, we can in the histoscope, we can make out till where is the fibrous bands are, and where you reach the myometrium. And once you reduce the insufflexion pressure, you can see the blood started oozing out. That's the time you have to stop the resection, sir.
Yes. Dr. Saravana Kumar, give your inputs.
Yes, sir. I agree with sir that I under resect, and probably majority of the patients they conceive even if you don't do a complete cutting of the septum till the myometrium where you reach. Probably they say that if you see that pinkish myometrium, we have to stop. But usually the a sort of endometrium resection till we see the fibrous bands is enough. Enough whatever I do. And I usually use a scissors only.
And Dr. Manoj, any input?
I used to cut the septum till we can see both the ostia in a panoramic view. And till we get the red myometrium, that is the bleeding point, that is my end point.
Correct. So when you reduce the pressure, that vessels do appear pink, and that does help. Keshav, how do you how do you decide when to stop?
Yes, so the level of the osteas is the indicator, and you slightly reduce the pressure and see those vessels bleeding, and slightly you inflow. If you reduce it, you can see the vessels bleeding, and I think that is like the end point where you see that pinkish tissue. One case I would like to mention where I had perforated the uterus with the current. In that case, what we did was what we used to do, we used to just do bipolar by doing laparoscopy. But then what we realized is that suturing is better. You have to just take a stitch there if you are perforated, just a figure of 8 stitch. One thing is provides good integrity, and because one of my cases after that had perforated when she was pregnant, she got pregnant, and at 22 weeks she actually landed up with a uterine rupture, and it was at the same level where we had taken the cautery. So what we have to do is we have to take a stitch, is one point that I would like to mention for all the viewers here.
Yes.
And another thing is, if you are perforated using a electric current, always go and explore the bowels.
Yes,
There
100%.
is the possibility of a bowel injury.
Yeah, 100%.
Yeah.
That is quite true. I mean, you have to rule that out. I feel that suppose if I have perforated with a scissor, then I might be able to skip the suturing part because there is no ischemia. Healing is not affected. But if earlier when I was using resectoscope, the concern was that only, that if it is the resectoscope current which has cut and perforated, then that level where the perforation has happened is ischemic. The healing is compromised. So perhaps that is where suturing would definitely be required. Otherwise, may not be required, and you can get away with just taking a look laparoscopically, making sure that it is fine, and leave it. Lateral metroplasty, very vague situation. Lateral metroplasty as to probably what is your experience and what is your suggestion related to this procedure?
Hello.
Yes.
In case of the septum, I am going ahead with the lateral metroplasty because some in the other way it works as a scratching the endometrium. So I
Yes.
believe in doing lateral metroplasty.
What do you use for that? You are using a scissors, or are you using?
I'm comfortable with the scissor. I'm not using the resectoscope, considering the endometrial ischemia and all this myometrial ischemia with the
Yes.
current.
Keshav, what is your experience with?
We don't do it in all cases. If we have an HSG which is showing a typically narrow T-shaped kind of uterus in those cases, and in infertile cases where the endometrium thickness is an issue where it doesn't grow beyond 6 mm on serial folliculometry, in those cases we try and do metroplasty. And sometimes if the endometrium really is a factor, even that doesn't help, but majority of cases it has given positive good results, I would say.
Yes, I also
in
do agree.
indicated cases.
Especially if we see the cavities too narrow and small, then you can go for a lateral metroplasty, and preferably with scissors, not with cautery.
Only scissors, yeah.
Only scissors.
Dr. Saravana, any input from your side?
I don't do a metroplasty, sir. Many times I have seen patients who have undergone metroplasty and then come back again with us for adhesion formation. And so I usually don't prefer to do a metroplasty on the lateral side.
So obviously you do have to be judicious about how much you are going to cut. Once I have encountered a spurter in one of my own patients. So that is being a little too enthusiastic about it, and then ended up cutting into the vessel. We had to go in laparoscopically and cauterize the uterine from that side. So you have to be a little careful. Even I am not too fond of lateral metroplasty, but like we have discussed that sometimes mainly in unexplained situations, that is where I do prefer ki theek hai, the cavity then starts appearing narrow. It's a subjective appearance. So and coincidentally, whatever lateral metroplasties we have ended up doing, like I mentioned, we are not very enthusiastic about it now. So I don't cut too much, but coincidentally, whatever we have done, we did have good output, and incidentally, they have actually conceived also. So we can probably leave it to fate. I mean, it's patient's luck which decides on whether it is going to be beneficial or not. So from the perspective of endoscopy in infertility, I would like to ask each of you to give some specific carry home message from your side. Like, for example, to begin with, I would always say my main purpose of any surgery which I am doing in infertility is to use minimum cautery or no cautery, mainly to prevent ischemia, whether it is on the ovary, it is on the myometrium, or it is on the endometrium. Each and every surgery that I do, I have a habit of trying to minimize the use of cautery in the entire surgical procedure. And probably that is one of the reasons why in everything I'm using vasopressin except hysterectomy. So similarly, from each of you, I would like to ask whether you would like to give a very clear, your personal experience of the last whatever number of years you have been operating. What is the change or what is the specific principle in practice which you would like to talk about? Let's start with Sundar. What would you?
One thing is actually we have to be very selective about the cases, sir. So
it takes, yeah, it's a saying, it's a common saying, it takes 2 years to learn how to operate, and then it takes 20 years to learn when not to operate.
Yeah, it is with the flourish of ART, a lot of procedures previously what has been taught, which has to be done as like what do you call it, the laparoscopic ovarian drilling and other procedures. Now they are on the decline, sir. That is one
ovarian
thing.
drilling, I think nowadays I haven't come across ovarian drilling in my center for years now.
Yes, sir. Yes, sir. Yeah. So that we have to be judicious, one thing. Second thing is tissue handling, sir. We have to be very careful about tissue handling, especially with what do you call the endometriomas and other things. We have to try to conserve the ovarian tissue as much as possible. So we have to be very judicious in using, especially cautery, and whenever it is possible, we have to use as much as possible a bloodless field, sir. And because basically we are all more conservative surgeons compared to a general surgeon. We are not a radical surgeon. We are more a conservative surgeon, and especially from the infertility point of view, we have to be more conservative. So
very true. Very true. So, Dr. Keshav, kindly give your inputs.
Yeah, first of all, I would say that DHL's diagnostic laparoscopies or hysteroscopies are not to be taken lightly because they are like Pandora's box. Sometimes when we put in a scope, we end up spending a much more time in those cases rather than a clear-cut hysterectomy. So sometimes even in the entry, the trocar entry in such cases, we have to be very judicious, whether it could be a Cox abdomen or a PID. So use the Palmer's point and use those points also, because you just can't go in and think that this procedure would be over in 10 minutes, because sometimes it does, but many times it could land you up in trouble. And also do a complete job from fertility point of view. Even if you are going with the point of view that there is tubal block and she turns out to have endometriosis, I think you have to clear those endometriotic implants also, so that she has a better job of getting pregnant, which is our ultimate aim. So don't take them very lightly as most of the gynecologists do. Yeah.
That is actually a very valid point. I mean, couple of times it does happen that you post it as a DL scopy and then there is an ovarian cyst and you end up spending time for that, or maybe it turns out to be a small myomectomy also.
Yes.
So that is very true. Dr. Saravana Kumar.
So we have to be careful about post-operative adhesion formation. Because we don't have our medical college does not support all these adhesion barriers and all. So we leave a lot of fluid inside. And despite and the other thing is we have to see that there's not much of I mean the whole field is clear of blood, because that will again cause adhesions. Because I had a patient who was a second gravida who developed my fibroid, and I did a myomectomy. She had peritubal adhesions. So that's one thing we have to be very careful about in doing.
Yes. I think tissue handling does make a difference in the preventing adhesion formation. I personally have a habit of leaving 1 liter saline. I would like to believe that it helps in preventing adhesion formation, though there is nothing documented in the books or in the articles. But let's see. Manoj, what is your input?
Generally, I used to do laparoscopy in cases of unexplained infertility, unless and until indicated, and not in all cases.
Yeah, that is But laparoscopy is now becoming very common. I mean, suppose I have an infertility patient who has not undergone an HL-scopy. I usually end up, from my perspective, telling them that no, you get it done before we initiate cycles, because everybody is in a hurry. Even the patient is in a hurry. And sometimes we do end up having patients who have taken treatment for a number of months, and then they come up and some small factor is there, which creates a easy solution after laparoscopy. Before we wind up, I would like to thank all the panelists for your wonderful inputs and for participating in this particular program. I would again like to thank Dr. Sampath Kumari and Madhumita for this wonderful opportunity. And thank you all. Thank you very much.
I would also like to thank you and the team. Thank you so much.
Thank you so much, Rajesh sir, Saravanan sir, Keshav sir, Sundarnarayan sir, and Manoj sir for the wonderful session. So for the formal vote of thanks, Pradnya ma'am. Yes.
Yeah, I would like to really thank our moderator, Dr. Rajesh Modi sir, and all our panelists today. I think all the inputs were so great for infertility and endoscopy. Also, I would like to thank our convener, Dr. Sampath Kumari madam, for giving me and Madhumita the opportunity to have these webinars. And also our speaker for today and our chairperson. So thank you, everyone. I think it was a great session today.
Thank you. Thank you all very much. We'll be logging off. Thank you.
Thank you.